We've all heard that tired old saying, the one about dermatology. The patient never dies and never gets well.
Right. It's a classic, but it paints such a misleading picture of the specialty today.
It really does, because if you are training in modern critical care or emergency medicine, you know that this just couldn't be further from the truth.
Not at all.
I mean, contemporary dermatology is so often right on the front lines dealing with actual life-threatening emergencies.
Things that require incredibly rapid, decisive management. And that's really what we're here to talk about. This is a deep dive into a field that is anything but skin deep.
Exactly.
So for you, the medical learner, think of this as a comprehensive summary. We're pulling all the high-yield knowledge from key emergency dermatology sources.
And the mission here is pretty clear.
It is. We want to give you that scientific clarity, but also the practical applications you need to recognize and manage things like acute skin failure, high mortality infections, and catastrophic drug reactions.
Often in situations where every second counts. So we're going to unpack the most critical concepts building from the ground up. I'm talking molecular level cellular processes all the way to these huge systemic reactions. So let's start with the absolute basics of pathology. How cells die.
Right. And we need to draw a really clear line between apoptosis and necrosis.
Okay.
So apoptosis, that's programmed cell death. It's often protective. It's, an organized, systematic way for the body to get rid of damaged or infected cells without triggering a massive inflammatory response.
Just neat and tidy.
Very neat and tidy.
Yeah.
Necessary for healthy tissue.
But necrosis is the complete opposite, messy and chaotic, right?
Exactly. Necrosis is destructive. It's messy. The cells lose their membrane integrity. They spill their contents. And these contents are what we call DAMPs, or damage-associated molecular patterns.
And then those are a huge red flag for the immune system.
A huge inflammatory signal. It doesn't just damage the local tissue. It kicks off a systemic inflammatory response that can, quickly overwhelm the body. And this chaotic cell death is central to understanding acute skin failure, or ASF.
So acute skin failure isn't just, the skin sloughing off. It's a functional crisis. What are the main triggers?
We can break them down into two main buckets. First, you've got direct trauma. Thermal burns are the most common, the most immediate cause.
And the second?
The second is often more insidious, especially for a general practitioner. It's systemic failure. This happens when the cardiovascular or renal systems are so dysfunctional that you get hypoperfusion of the skin.
So when the body goes into shock.
Exactly. It prioritizes the core, the brain, the heart, and it effectively shunts blood away from the skin.
So skin signs literally become mandatory indicators of impending systemic collapse.
They're a warning sign that the largest organ is being starved of oxygen and nutrients. And that failure at the micro level brings us right to crisis management, the ABCs.
Airway, breathing, circulation.
Correct. Stabilization is always paramount. In burn patients, for instance, we're immediately worried about inhalation injury.
Right.
That patient needs to be in a specialized unit because something like laryngeal edema might not even show up for 24 hours.
And looking at that C for circulation from an ACLS perspective, what are the key takeaways from the sources on drug administration in pulseless rhythms?
The primary importance, always, is high-quality basic CPR and early defibrillation. That saves lives.
But pharmacologically?
Pharmacologically, for pulseless VF or VT, the go-to is epinephrine. 1 milligram live IV every 3 to 5 minutes. Vasopressin used to be in there, but current guidelines really prioritize epinephrine.
I know some sources question the value of epinephrine's beta-adrenergic effects, the fact that it increases heart rate and oxygen demand. Is that a real concern when you're just trying to get perfusion back?
That's a really sharp question, and the sources confirm that the primary life-saving effect of epinephrine in an arrest comes from its alpha-adrenergic properties.
The vasoconstriction.
It's a powerful vasoconstrictor. It increases the mean arterial pressure during compressions, and that significantly improves perfusion to the brain and to the coronary arteries. The beta effects do increase myocardial work, which is why we avoid high-dose epia, but that vasoconstrictor effect is absolutely essential.
Okay, moving beyond cardiac arrest, let's talk hypertensive crisis, another scenario where minutes matter. Blood pressure over 200 over 120.
The crucial distinction here, clinically, is hypertensive urgency versus hypertensive emergency.
And it's not just the number.
No, the number itself is less important than the evidence of end organ involvement. Are you seeing encephalopathy, an acute MI, an aortic dissection? If those organs are failing, It's an emergency.
And in that emergency setting, what are the goals? What should learners focus on?
You need to reduce the mean arterial pressure, the MAP, by about 25% within the first hour. That reduction is critical.
How do we do that?
Well, if the patient has pulmonary edema, the go-to is a combo of an IV loop diuretic like furosemide with a vasodilator like nitroglycerin.
And without pulmonary edema?
For a general hypertensive emergency, IV agents like labetalol or nicardipine are often preferred because you can titrate them for very precise blood pressure control.
Okay, great.
Now, let's pivot to something that requires really rapid pattern recognition, life-threatening bacterial syndromes that show up on the skin. There are three big ones: necrotizing fasciitis, toxic shock syndrome, and staphylococcal scalded skin syndrome.
Necrotizing fasciitis, NF, is terrifying. I mean, the initial presentation can look so benign. Why does the deep infection spare the surface at first?
It's because the infection is just spreading along the deep tissue planes, the fascia, much faster than it spreads up through the epidermis. It's a true stealth infection.
So what's the tell?
The critical diagnostic clue is the pain, disproportionately severe pain and tenderness. If you palpate the patient, the area of pain extends far beyond what you can see, the visible redness. You might also feel crepitus, that crackling sound under the skin, or what you call woody induration, a hardness that signals deep tissue compromise.
So that pain discrepancy is the red flag that screams urgent surgical debridement.
You cannot wait. With a mortality rate of 25 to 40%, you just can't wait for lab confirmation. You have to act.
Okay, another critical distinction. SSSS versus toxic epidermal necrolysis, or 10-APN. This is a vital one.
Absolutely vital for management.
So let's break down SSSS first. What's the mechanism at the molecular level?
SSSS, which we mostly see in children, is toxin-mediated. The staphylococcal exfoliative toxin acts like a tiny pair of scissors, a protease, that specifically cleaves a protein called desmoglein-1.
DC1.
And crucially, this cleavage happens very high up in the epidermis. It's subcorneal. The deeper epidermis is still viable, which is why the mucosa is typically spared and the blisters are so flaccid.
Now compare that to 10.
10 is a completely different beast. It's an acute, severe drug hypersensitivity reaction, usually in adults, with a very high mortality. Instead of that superficial split, 10 causes full-thickness necrosis of the epidermis.
So the whole top layer died.
The whole top layer. This leads to widespread, incredibly painful mucosal erosions, mouth, eyes, genitalia. On a biopsy, you'd see subepidermal splitting.
So the location of that split subcorneal versus full thickness, that determines everything.
Precisely. For SSS, you need to hospitalize and give systemic IV anti-staphylococcal antibiotics, like methicillin, to kill the source of the toxin. For 10, you have to immediately stop the offending drug and get them to a specialized unit, like a burn center, for intensive supportive care. The paths could not be more different.
And before we move on from infections, it's worth a quick mention of Rocky Mountain spotted fever, another tricky one.
Very tricky. The diagnosis is often delayed because that classic triad of fever, rash, and headache is often absent or delayed. And we know that any delay in starting the right anti-rickettsial therapy is strongly correlated with bad outcomes.
Okay, so speaking of severe drug reactions, let's circle back to SJS and 10N. Learners always ask about adjunct therapies beyond supportive care. What do the sources say about things like IVAJ or corticosteroids?
Yeah, that's a common question, and the honest answer is that their efficacy is still controversial.
No clear winner.
No. We just lack good randomized clinical trials on corticosteroids. And while IVIG has been used with the idea of blocking keratinocyte death, studies show really mixed results on whether it actually impacts mortality.
So it comes back to the basics.
It absolutely comes back to supportive measures, fluid and electrolyte management, infection control, wound care. That is what saves lives here.
This brings us to the acute complications from modern systemic therapies that are common in dermatology. Let's talk methotrexate, or MTX. What acute toxicities do clinicians need to have on their radar?
The most dangerous one is bone marrow toxicity, pancytopenia. It can develop suddenly and rapidly.
And the mortality rate is high.
Terrifyingly high, somewhere between 17 to 44%. And learners have to know that risk factors like pre-existing renal impairment or using certain antibiotics at the same time, they significantly raise that risk. Early recognition and immediate rescue with leucovorin are essential.
And we can't forget MTX pneumonitis. That's a serious hypersensitivity reaction.
Yes, it can be subacute, but a life-threatening acute form can progress in just days. It carries about a 13% mortality rate. If you have a patient on MTX with pulmonary symptoms, you have to rule it out.
Then you have the biologics, especially the TNF-alpha inhibitors. They introduce a whole new layer of acute risk,
That do, which primarily includes opportunistic infections.
like tuberculosis.
Exactly.
Yeah.
That's why pre-screening is mandatory. But critically, for patients who live in or have traveled through endemic regions, like the Ohio and Mississippi River valleys in the U.S., the risk of fungal diseases like histoplasmosis also goes way up.
So you need a good travel history.
A comprehensive geographic history. And we also see some rare cases of drug-induced lupus, which is usually reversible when you stop the biologic.
Let's close out this section with anaphylaxis, the classic type IgE-mediated reaction that demands immediate action.
It's important to know the high-risk patients here. Anyone with pre-existing cardiovascular disease or patients taking medications like beta blockers, they're at a much higher risk for a fatal reaction.
And management is standard.
Standardized. Intramuscular epinephrine is the required first-line therapy. And you must do an extended observation period afterward to watch for a biphasic reaction where the symptoms come roaring back.
On the prevention side, for severe insect sting allergies, venom immunotherapy is surprisingly effective.
It's highly effective. The sources put its success rate somewhere between 75 and 98%. It's a really powerful preventative tool.
Okay, let's dedicate this last section to environmental exposure toxicology and some key neonatal emergencies. First, prevention of vector-borne disease. What's the standard advice?
DEET is still the standard repellent. It's widely available, long safety record. The rare severe reactions you hear about, like toxic encephalopathy, are almost always from misuse or ingestion.
What about permethrin?
The key thing to remind patients is that permethrin is neurotoxic if you put it directly on your skin. It is only for clothing and fabric.
Okay, now shifting to toxicology, how do we spot key metal poisonings from skin signs? Let's start with arsenic.
Arsenic poisoning, whether it's acute or chronic, has two pretty distinct signs. First, you have Mies lines.
Yeah.
These are transverse, whitish bands on the fingernails
Right.
that show up about 2 months after exposure.
2 months, okay.
And second, you have acral hyperkeratosis, which is a thickening of the skin on the palms and soles.
Mm.
Management for both is supportive care and chelation therapy.
And what about mercury? That has a classic systemic triad.
It does. Chronic exposure to elemental mercury gives you intentional tremors, a state of excitability called erethism, and severe gingivitis.
Is there a skin sign?
Yes, there's a very specific one that correlates with ingested mercury, often from contaminated seafood. You see small, flesh-colored papules, mostly on the palms, soles, and trunk.
And dioxin exposure, like from a chemical accident.
Systemic dioxin poisoning has one clear hallmark: chloracne. It's not like typical acne. It's mainly non-inflammatory, comedones and cysts, and they have a very specific distribution mile or crescent, behind the ears, armpits, groin. It typically spares the nose and limbs and is really hard to treat.
Finally, we have to touch on two very high-stakes neonatal emergencies where the skin barrier is just not fully developed.
First, neonatal herpes simplex virus, HSV. This is a true pediatric emergency. Mortality is incredibly high if it's untreated. You must start antiviral therapy, specifically systemic acyclovir, immediately on clinical suspicion. You cannot wait for lab confirmation.
And what about the extremely premature infants?
For the very low birth weight babies, under 1,000 grams, invasive fungal dermatitis, usually from Canada, is a huge threat. This is purely because their epidermal barrier isn't efficient. It's so poor that fungi can invade rapidly and cause a disseminated infection. That requires immediate parenteral antifungals and intensive and ICU care.
It seems like the core takeaway from all of this is that emergency dermatology demands vigilance, rapid pattern recognition, and decisive action.
It absolutely does. The skin is this crucial, visible indicator of an underlying systemic collapse, whether it's from hypoperfusion, a hidden infection, or a massive drug reaction. You have to act fast, often before you have all the lab results back.
Internalizing the subtle distinctions we've covered today is a life-saving skill. You have to know the difference between the deep, deceiving pain of necrotizing fasciitis and the severity indicators of a hypertensive emergency.
But maybe the most critical distinction is the one we highlighted with infectious reactions. So, to test your thinking right now, here is an exercise.
All right.
A 6-year-old child presents with a diffuse, painful, sunburn-like rash that started on the face and flexures. They have flaccid blisters and a positive Nikolsky sign. Crucially, their mucosal surfaces are spared. What's the most likely diagnosis, and what finding on a skin biopsy would confirm the mechanism of cleavage?
The diagnosis is staphylococcal scalded skin syndrome, SSSS, and it would be confirmed on biopsy by finding subcorneal cleavage. That's the result of the staphylococcal exfoliative toxin targeting and degrading desmoglein 1. Understanding that location is the key to everything. That's how deep the deep dive gets.